Our next talk is from Devin, Terhune and Mark Edwards, who are going to talk together on placebo, suggestion and FND interactions in closed pathophysiology. Mark, I don't think needs any introduction actually. So he's a professor of neurology at King's College London, and I think everyone knows him very well here for his work in FND and movement disorders. So you talking first, Mark? Yeah.
Wendy, it's great to be here and great to do a double act with Devin. I hope that we can take you through a kind of an interesting area which follows on really nicely from the previous talk, which was fantastic. Devin and I are going to talk together, and I'm going to start off with some sort of clinical and, I suppose, theoretical evidence about this overlap, or this interest of overlap between functional neurological disorder, suggestion and placebo. And then Devin's going to talk a bit about some empirical evidence. Then we're going to try and bring that together a little bit about, really from a clinical perspective, what that might mean or what it might not mean. So starting with the sort of historical and sort of theoretical side of things, as all of you know, there's been an interest in suggestion and through that hypnosis for a very long period of time, and that interest has focused significantly on functional neurological disorder. So here's some sort of greats of the 19th century with regard to FND, who all had an idea that suggestion and hypnosis was important in some way in FND, whether it was something important in the genesis of it in the first place as a model or perhaps as a treatment. So Charcot certainly thought that hypnosis was an interesting model and treatment for hysteria, and wanted to highlight the fact that he was talking about suggestion, really. So he said, well, suggestions can be applied without hypnotism, and maybe as effective as hypnotism itself. So the idea that hypnotism and suggestion go together, and one might not need to have a lot of the sort of theatre that people might think of when they think of hypnotism in order to use this technique. Janet, with his idea of the suggestive effect of fixed ideas, which may be triggered by trauma, and Bernheim, who was a sort of certainly a critic of Charcot, but used hypnosis and later a sort of more suggestion without hypnosis approach for treatment. And if you want to read about those, Quentin Dede wrote a fantastic chapter in the Handbook of Clinical Neurology around functional neurological disorder about all of that. So there's certainly a history here of hypnosis and suggestion as relevant to FND, maybe thinking about as a model, as a treatment, etc. So you see that come through into more modern classification. So this is a paper by Tony Lang, which is about functional movement disorders. So this is in the movement disorder literature. These are diagnostic criteria, or think about how you would diagnostically categorize your confidence in a diagnosis of a functional movement disorder. And you can see that the sort of number one way of thinking about it is remittance with suggestion or placebo, amongst other things. And so this idea of response to placebo, response to suggestion, as being sort of gives you the highest level of diagnostic certainty. And that follows through into using suggestion in clinical practice as a diagnostic technique. So, for example, here here's Joe Jankovic giving somebody a suggestion that putting a tuning fork on their sternum is going to give them symptoms, and lo and behold, symptoms occur. I mean, you could argue about whether that's really necessary as a diagnostic technique. Maybe we have better positive diagnostic techniques of the symptoms themselves rather than need to do this, but it's certainly there. And then there's a large literature on using suggestive seizure induction. So this is looking at people who may have functional seizures or non-epileptic seizures, but you're not sure, maybe they have epilepsy, and that's a difficult, or can be a difficult, diagnostic conundrum. And one way of trying to solve that is to bring people in for video EEG, but that takes a long time, it's expensive. So maybe if you do something as an outpatient and you have an EEG on, but you give some suggestion, you do some sorts of techniques, you might bring on a seizure, an attack in people with non-epileptic seizures. And the bottom paper from Stoy and Poplar is actually doing that in an inpatient setting. So people who've been brought into hospital doing video EEG, but actually using suggestion as a way to either speed up the whole process or to get a seizure to happen at all. Because there are people who would come into hospital, you keep them in for 5 days and they don't have an attack, and then you're none the wiser. So it certainly has been used and continues to be used as a technique in diagnosis for functional symptoms. And then from a treatment point of view, it's there as well, and it's been there throughout history. So this first video is from the Second World War. You could have the sound on the video.
Emotional disturbance shows itself as a physical ailment. Here, an inner emotional distress has been converted into a form of paralysis. In this type of case, treatment under narcosis may yield extraordinary results. Here again, a sedative is employed. Under the influence of the drug, the patient's mind becomes more open and receptive. While the patient is in this highly approachable state, the doctor employs the power of suggestion to pave the road toward recovery. Now you're going to get right up and walk.
That's a military suggestion, I would say, not really a therapeutic suggestion.
Now get off the bed. Put your feet right down on the floor.
Okay, I'm going to move on just for the sake of time. With this next video, this is John doing therapeutic sedation. So this is under propofol. I don't know whether we can hear that video.
Walk right over to the ward, man, all by yourself. Go ahead.
Push away. Push up there. A bit harder, come on, a bit harder. Really hard, come on. Excellent, that's it. Just pull your heel towards your bottom. That's good, that's nice and strong, isn't it? That's good.
So you can see that, so this is under propofol sedation, John giving, it's nice and strong, I can feel it happening there, etc. So obviously there's lots of different ways in which Amortal and propofol sedation might work, which are not around suggestion, but suggestion is an important component of the whole process. And I'll talk a little bit about that later with some of Norman Paul's work as well. So you could argue that placebos have also been used in different ways over time in FND. So here's thinking about electricity. So here's a video from the First World War. This is a person in gate. An hour later after treatment, and that treatment contained some electrical stimulation alongside suggestion. And you could think of maybe that the same thing is going on in studies of transcranial magnetic stimulation in functional neurological disorder. So there are different ways that can be applied, and there's repetitive transcranial magnetic stimulation, which is more of a neuromodulatory effect, or could have a neuromodulatory effect. But people often use single pulse TMS, so giving a sort of strong stimulus which gives a muscle twitch. And this is a nice paper, I think, because people have argued, well, whether that's a neuromodulatory effect even itself, but here's getting similar benefit from either doing that in the motor cortex or just stimulating at cervical level and producing a muscle twitch. So there's something about the sort of that whole process of potentially seeing the body moving again and then changing belief. So there's also, lastly, a sort of theoretical way in which this is relevant. So there's this overlap between suggestion, placebo, and FND. So thinking about how human beings work, we're definitely more than stimulus response organisms. So even something which is really an obvious event, like shutting your hand in a car door, your conscious experience of that is something which is mediated through a neural process, a neuropsychological process. And we know a bit about the sort of underlying kind of neurobiology of that, I suppose, in that there's two sources of information that go up together to form a conscious percept. So there's the sensory data, there's the stuff coming in, but there's also expectations or predictions about what that data is going to be. So that's why I put this picture up of people playing tennis, because the person about to hit the ball has quite a lot of sensory information coming in from his visual system about what he needs to do, where his body needs to be. But the people on the other side of the net are not standing still, they're already moving with a prediction about where that ball is going to go. And the person back on the other side of the net is performing an even more meta calculation about where the ball's going to go and then where these people are going to hit it. So this predictive system is important, and attention is clearly very important in that. And that's been part of the way that people have thought about lots of different conditions, including FND. And there's a sort of overlap in the way that you might use that sort of model in thinking about FND and thinking about placebo and nocebo. So on these graphs here, always using the same scale. So the blue is what's actually coming into the system. The red is the expectation the person has about that input, and the percept is the grey. So you can see how these different probability distributions, so the different strengths of these types of information, can alter the percept. So in the idea of maybe functional sensory symptoms, that you have a very strong expectation that there's going to be abnormal sensation, for example, pain, and actually normal sensations coming in, but you can't experience that because of the strength of this abnormal expectation. But you can see the same thing you might expect. You could explain a placebo effect in the same model and a nocebo effect in the same model. And that's potentially relevant because there are things that happen to people at the beginning when they develop functional symptoms, which are quite common. So physical illness, physical injury, health events are very common in the time just before people develop functional neurological symptoms, often in association with panic symptoms, but usually without the recognition by the person that they have panic. So could you think of those as a sort of auto-suggestion almost, or a nocebo that's happening within the body? And even more, the sort of expectations that people have, they clearly mould long-term experience. So the really nice studies done in the 2000s, I expect it may not be the same anymore, comparing population in Lithuania and people in Edmonton in Canada about just healthy people, about their expectations about what would be likely to happen if you had a minor rear-end traffic accident. And you can see that across the board, while people generally think that you would have some symptoms, and symptoms which make more sense, like having neck pain, are more strongly validated by everybody, the number of people who think that those symptoms are going to extend for months to years in Lithuania at that time was very, very low compared to people in Edmonton, Canada. And the population incidence of a chronic whiplash syndrome at that time were very, very low in Lithuania and relatively high in Edmonton. So that's a beginning of some sort of theoretical clinical evidence. I'm going to hand over to Devin now to talk through some empirical evidence.
Thanks. So I'm going to take you through a bit more of the theoretical context for some of the debates regarding suggestibility in FND and dissociative psychopathology more broadly, and also take you through the evidence. So first of all, when we think about suggestion, a nice context to think about this is in the context of something like the placebo response, where we have a nice image here of a doctor giving an injection to a patient. The placebo response is incredibly complex. There's a lot of factors involved. There's the internal context of expectations, beliefs, prior associations the patient has. There's the conditioned associations where the patient might come to condition a positive association between a doctor's and positive outcomes and so on. What I really want to focus here, though, is on verbal suggestions, which are going to be incredibly commonplace in a wide range of therapeutic contexts. So here, this is going to make you feel better. So we typically define a verbal suggestion as a communication for an involuntary response, something that is happening to you as opposed to something you are voluntarily, actively producing. Now, despite the backdrop of this long-standing link between suggestion, suggestibility, FND, dissociative psychopathology, this has actually been the source of a great deal of controversy, particularly in the context of the dissociative disorders over the last 10 to 15 years. So in particular, about 10 or 15 years ago, you see the emergence of what's been called the social cognitive model, where they argue that suggestibility actually plays a causal role in producing dissociative symptoms by rendering individuals prone to false memories of trauma and various types of dissociative states. Needless to say, it's incredibly controversial, but it's working with the idea that dissociative phenomena and various types of functional phenomena are ultimately a form of iatrogenesis. Here you have in the middle the kind of the dominant theoretical strand in contemporary work where trauma exposure is the primary causal antecedent of the dissociative disorders. Now, interestingly enough, these two models have been kind of debating this over the last 10 to 15 years. There's been a lot of kind of infighting about it, but they've actually ignored a kind of a classic model from the 1990s, the diastasis stress model of dissociative psychopathology, where the basic idea is that direct verbal suggestibility functions as a predisposing factor to dissociative states in response to trauma. So highly suggestible individuals are just more vulnerable to dissociative psychopathology in response to trauma and stress. But this old model has largely been ignored in classic or in more recent discussions. And so in a recent review, paper concluded studies have typically yielded mixed findings or weak or modest correlations between false memory, suggestibility, and dissociation. So despite this long-standing link between, or suspected link between suggestibility and dissociation, these researchers, those endorsing these two models, have concluded there's not really much going on between suggestibility and dissociation. Now, what I want to argue is this is a complete misunderstanding due to the heterogeneous nature of suggestibility, which I'll return to in a moment. But what I want to particularly flag here is how false memory is equated to suggestibility here. And this is very much a misunderstanding that's been propagating in this field. So the thing I really want to impress upon you is the importance that suggestibility is not a uniform domain. It's an incredibly heterogeneous phenomenon. And if you look at kind of factor analytic work, there's actually pretty good evidence for two distinct forms of suggestibility. So on the top, we have what's often referred to as direct verbal suggestibility. This is typically what's studied in the context of hypnosis, but also, as Mark highlighted, outside of the context of hypnosis. When we talk about direct verbal suggestions that a GP might be giving to their patient, we're really talking about direct verbal suggestibility. This pill is going to reduce your symptoms. This treatment might cause side effects. That's direct verbal suggestions. On the other hand, on the bottom, we have what you might call forensic or interrogative suggestibility. So this is suggestibility that's relevant to the induction of false memories, distortions in eyewitness testimony, these types of effects. And it's really kind of the emblematic example. This is the Gudjonsson suggestibility scale, which is the most widely used measure in the forensic context. Now, what's really important to emphasize is that when you do factor analytic work on it, these two forms of suggestibility are almost completely orthogonal to one another, and they're basically not correlated at all. Now, what's really striking, and we were kind of really blown away by this fact, is that all the literature recently on dissociative psychopathology and suggestibility, where they've been kind of debating this, it's all on forensic suggestibility. There's no mention of direct verbal suggestibility in any of those papers at all. It's actually incredibly striking, right? So against this backdrop and against this whole idea, just to say a few things about what we do know about direct verbal suggestibility and why it would be relevant here. So we know that it is highly stable over time. This has been demonstrated over 15 to 25-year periods. We know there's pretty good evidence that's heritable, although its genetic basis is very poorly understood. Of relevance to the present context, direct verbal suggestibility does occasionally predict individual differences in responsiveness to placebo and nocebo manipulations, but it's important to emphasize these correlations do tend to be weak, so I don't want to make any strong claims about that, because the placebo responsiveness doesn't exhibit the trait-like characteristics that you typically see with suggestibility. An example of this is from a study by one of our former students, Ryan Parsons, where you find that non-hypnotic suggestibility weakly correlates with an experimental model of placebo hypoalgesia in the lab. Okay, so these are relatively weak effects, but there seems to be some type of potential link there. Mark has already covered how we can conceptualize suggestion and FND within the context of Bayesian models, but again, the basic idea that we're typically working with is that suggestions affect very precise priors or expectations that bias your perception away from actual sensory data to produce new anomalous perceptual states of various kinds. So what is the actual evidence? So 2 years ago, my PhD student, Ruki Wieder, she published this paper where we did a meta-analysis of all suggestibility studies in functional neurological disorder. So on the left, we looked at standardized suggestibility scales. So these are standardized scales that are widely used, such as in the clinical and experimental hypnosis literatures, but even outside those literatures where you have non-hypnotic measures of suggestibility. And so what we found overall was that FND is characterized by elevated suggestibility. It's important to emphasize it's a relatively moderate effect, but it's fairly reliable. On the right, we have symptom suggestibility. So Mark already introduced to you how you can use verbal suggestion to induce symptoms. So he referred to as suggestive seizure induction, for example. So we accumulated all those studies and looked at that effect, and that indeed was also statistically significant, but also a much larger effect, so almost a 1.5 standard deviation effect. Now, notably, you still have considerable heterogeneity in FND. So you only have about 50% of patients on average respond to these suggestive symptom induction techniques. So it's important to emphasize this is not a uniform characteristic of all FND patients. It's really important to emphasize that. Recently, Ruki extended this further to look at whether this was a broader feature of dissociative psychopathology more broadly. So in this second meta-analysis, she contrasted dissociative disorders, trauma and stressor-related disorders, so PTSD and FND, found that all three of them were all characterized by elevated direct verbal suggestibility. So this completely goes against the kind of the theorizing that's been going on in this literature regarding the trauma model and the social cognitive model. And overall, it's a relatively large effect, so nearly a 1 standard deviation shift. There is some variability here, and I'm going to come back to that in a little bit. These effects can also be observed in non-clinical samples as well. So we did a study where we have 1,100 participants where we looked at their membership in the dissociative taxon. So this is basically a subset of items that seem to be indicative of pronounced dissociative symptoms as a function of suggestibility. So each of these red markers represents 110 participants. When we randomly shuffle the data, we find that about 7% of participants in the sample meet some type of threshold for significant dissociative symptoms. Whereas highly suggestible individuals, this last percentile group, this is 18%. So it's it's more than twice what you'd expect when you just randomly permute the data. So again, this kind of provides further evidence for some type of link between dissociation and suggestibility. These effects also are observed in other conditions that are presumed to be reflective of functional mechanisms, or at least have parallels with FND. One of my favorite examples is that of mass psychogenic illness. A really nice example of this is the Havana syndrome, of course, where US diplomats report various types of symptoms in Cuba and misattributed this to the Cuban government having a supersonic weapon that defies the laws of physics, right? Now, what's really nice is a paper by Sapkota in 2020 studied a very large sample of children who had experienced mass psychogenic illness and compared them against a control group. They found the #1 predictor of whether they had had mass psychogenic illness symptoms was suggestibility. It was a stronger predictor than dissociation, than trauma, than anxiety. Another example of this is idiopathic environmental intolerance, where individuals will misattribute various types of unusual symptoms to environmental stimuli, wind turbines, for example, electromagnetic fields, telephone lines. We again found that suggestibility is a fairly reliable predictor of these types of symptoms, independently of both dissociation, trauma, and other features. Now, one I think important takeaway here is we think that suggestibility can help inform our understanding of heterogeneity in these conditions. We've only begun to do preliminary work on this, but I really want to flag this in particular. So one notable finding that came through in our meta-analysis is that the dissociative disorders were characterized by elevated suggestibility compared to PTSD and FND. So FND and PTSD were still lower than the dissociative disorders. So we think this kind of may help us to inform both overlap between these conditions, but also fundamental and important distinctions. Another important element is that these are all the studies where we found that suggestibility is associated with greater symptom severity in a wide range of different conditions. So it seems that highly suggestible individuals on average tend to have more pronounced symptomatology. And we see this in PTSD, dissociative disorders, eating disorders, FND, that these individuals seem to be just more prone and vulnerable to a wide range of kind of exacerbated symptoms. Now, you might start to think, okay, well, maybe just suggestibility is some type of artifact or feature of generalized psychopathology, and that was something we're concerned about, because there is always a chance that in this field that there's a bit of a confirmation bias where they're focusing on FND, dissociative disorders, and so on. So if we map this out, this is from a meta-analysis by Lysenko, where they looked at 18 different psychiatric disorders. And so here you have dissociative disorders, PTSD, borderline, and so on. And here you have anxiety, depression, bipolar, and so on. So in red, we've identified disorders where we see typical or relatively normal levels of suggestibility in these conditions, whereas elevated suggestibility is observed in these. This is kind of still quite preliminary, but there seems to be some type of link between the more pronounced dissociative symptomatology, the more elevated the suggestibility is. So some degree of specificity with regard to dissociative psychopathology. Now, one thing I think it's often lost in this kind of discussion, particularly in the debate that's been going on between the socio-cognitive model and the trauma model, is that all these data are ultimately correlational, right? We really have to remember that. So we're very interested in the possibility of moving beyond correlation by focusing on NMDAR antagonists such as ketamine and nitrous oxide. So there's some preliminary work that dissociation is associated with reduced glutamate concentrations in anterior cingulate, and there's a little bit of other indirect evidence for that. We know that NMDAR antagonists like ketamine and nitrous oxide reliably induce dissociative states. Importantly, we also know that they enhance direct verbal suggestibility. So we're currently pursuing this with 25% nitrous oxide. In some preliminary work, what we have indeed found was that even at 25% nitrous oxide enhances depersonalization, derealization, amnesia. It also enhances suggestibility, but critically, it doesn't enhance psychotomimetic states like hallucinations and delusions. So we think this is a really important avenue to kind of try to more carefully probe the interrelations between these effects. So I think I'll leave it back to you. We heard about a truth sandwich. We have a Mark Edwards sandwich here. Okay.
So, having heard that sort of empirical evidence and this background of research, just thinking about how it might sort of bring that together into, particularly from a clinical perspective. So there is evidence from the functional imaging literature that is out there and obviously has its own issues, that there's a significant overlap between the networks that might be involved in placebo and nocebo effects and those networks that seem to be involved in the generation of functional symptoms. So that's interesting, but what does that mean from a clinical perspective? So many of us, and in particular John, have been banging on about the importance of communication and diagnostic explanation. And this is one of my favourite articles from John. If you haven't seen it, it's a great photo story in the sort of Jackie comic school. But it's when you boil down these sort of the way that people have been thinking about diagnostic explanation, it's often using techniques which would be directly borrowed from the hypnosis and suggestion literature, really. This is a lovely paper by Wendy Phillips and Quinton, and our dear friend Jason, who's unfortunately not with us anymore, and it's sort of giving some examples of the typical techniques that are used in hypnosis induction. And when I read this paper, one of the things that struck me is that I was never told any of this stuff. Never taught, because hypnosis is something which is, traditionally someone else would do that, and it has a mystery, and there's quite a lot of negativity that might be thought about it. But there's lots of things which actually we use and are good examples of good communication practice. So these sorts of techniques, like mind reading, you probably already know, or you're probably familiar. I'm sure that you've realised already that, and some people find that in this sort of indirect communication, which is less threatening. These sort of dependent suggestions, when you do this, this is going to happen, and so we can use these. Even people who are not not delivering clinical hypnosis can use these sorts of techniques and can learn these sorts of techniques in communication. There is some direct evidence that potentially using hypnosis can be a treatment for people with FND. So This is a really striking study of using that acutely, so a stroke physician trained in hypnosis, delivering a hypnotic treatment for people acutely presenting to stroke services who actually have functional neurological disorder. So that's 10% of people who attend the hyperacute stroke pathway actually have functional neurological disorder, and seeing some really dramatic, quick changes. These are older studies. There's 2 randomized trials from the Netherlands, one of which is positive, but then the bottom one here, adding on a hypnosis treatment to a sort of full-up neuropsychiatric rehabilitation program, didn't produce any additional benefit. But there's evidence here that potentially we can leverage hypnosis into clinical practice, or at least some techniques. But following on this idea that you know, maybe this is something that all of us could do, here's a couple of bits from Quinton's paper, and he was citing Moni and Karen Roloff's as well. And when I was reading this, I was thinking, well, these are things that exactly on this side, a physiotherapist who's expert in FND treatment would often do, often be using suggestion, getting people to think about their bodies in a different way. This would seem to be something that would be very relevant for somebody doing CBT, for people with functional seizures, to use these sorts of techniques outside the context necessarily of hypnosis. And Norman Paul and others have written about the way in which you could potentially enhance existing treatments with suggestion. So how important, for example, suggestion might be when doing abreaction, and that suggestion is maybe sort of mediating or driving the response, the positive response to that. So I wanted to talk just a little bit about placebo as well, and I know Matt Burke is going to talk a little bit, so I'm going to talk about this a small bit. Placebo is something that's been thought about and talked about a lot, and when you talk to clinicians who see people with functional neurological disorder, actually particularly outside the UK, use of placebo seems very, very widespread, although people often feel a bit anxious about talking about it. So here's some work by Karen Rolfanger about sort of talking to clinicians about using placebo in functional disorders. So, you know, basically there's this sort of position of ambivalence where, you know, it can help in this situation. I'm not very comfortable doing it, but, you know, it can work, and what else do we have, sort of thing. And this is an example of a patient who's got a fixed dystonia, and she's about to receive botulinum toxin. Botulinum toxin takes about 2 or 3 days to block the neuromuscular junction. She doesn't know that. She's been given lots of suggestion that this is going to be helpful for her dystonia. And now she's all better, or so it might seem. But is she really? So my experience with doing this is that most people relapse very, very quickly, and then they may again respond to treatment, or they may not. So that got me to thinking that a lot of the literature on placebo and thinking about the ethics of placebo is between this, you know, this deceptive issue, or should we be using an open placebo? That's a very important debate. But there are some other things about using placebo which I find a bit troublesome. So this, to me, is getting better by magic, and so it has no self-efficacy at all. So even if you explain, even if it's done in an open way, it's something which could, certainly in this situation, or giving people saline, for example, injections of saline, it requires a physician or a health professional to be there to do it. It's not something that somebody can do themselves. It's only about the symptom, really. It's not talking about anything else around the symptom, and obviously we know that those are often the most important things that we're trying to change. And even if you're just talking about symptom reduction, there may be much better ways of doing that. So I think thinking about placebo is important, but often the debates just seem stuck around deceptive and open placebo, and not beyond into thinking about, well, what's the actual relevance of this, and what's its place amongst the other things that we can do. So and Catherine Hughes has done a very, very large survey, which is in preparation, just actually thinking about this. And I think this is the largest survey of patients and doctors about their attitudes to placebo. And it's a busy diagram, just to highlight a few things. So this is patients with neurological illness, many of whom had FND, healthy people, doctors, many of whom are neurologists, and thinking about their attitudes. So the one at the top, should doctors use deceptive placebo? I think interestingly throughout this, healthy people are much more up for placebo of any sort than anybody else. And you can see that professionals are usually the most anxious about using placebos. But you can see there's similar levels of thinking that it's okay between patients with neurological conditions and people with functional neurological disorder. And then at the bottom, thinking about could placebo improve your symptoms? Again, healthy people are much more enthusiastic that might do, if they did have symptoms, that a placebo could help. And that professionals in general at the bottom being more okay, or thinking that a placebo would be more likely to help in people with functional symptoms than other conditions. So I think it's important to do this work to think about the sort of the professional and public and patient support for the use of placebos if we're going to take them further in clinical practice. So just to finish with the thinking about how things go wrong in clinical practice as well, and thinking about that in a nocebo effect. All of those of you who see people with functional neurological disorder realise that the beginning of our pathways is actually quite normal. It's quite okay, because it's a patient going to see a doctor and the patient's got neurological symptoms and the doctor does something sensible, like sends them to a neurology clinic or they go to A&E, etc. But then there's a whole load of problems that start, which is some of which are around diagnosis. So, but actually more and more now, not actually making the diagnosis, but it's more about explaining the diagnosis. And then there's nowhere for people to send patients, so they end up in a sort of vortex where there's actually lots and lots of different services they could be referred to, but no stratification or integration between these services. So the structures of our clinical pathways are directly anti-therapeutic when it comes to people with functional neurological disorder. And if we're saying a proportion of people with functional neurological disorder are highly suggestible, maybe they're particularly sensitive to placebo and therefore nocebo effects, you can see that this is a particularly bad way to treat people. And so within these pathways, you have enormous activity, enormous expenditure, but most of it is not on the things which seem to make people any better. And so you end up with this situation of a highly stigmatized group of people with chronic symptoms. So thinking about how our understanding of nocebo and suggestion effects actually are implemented into what we do in clinical practice is, I think, very important in developing clinical pathways, and trying to co-design clinical pathways with patients is important. And just to finish with, I mean, this is been an area of interest for a long period of time. And there's ways in which we might go forward from here. So thinking, as Devin was saying, it's not everybody with functional neurological disorder who seems to be highly suggestible, but maybe there's a proportion of people, and maybe they have different responses to treatment. Maybe there would be different types of treatment would be relevant to them. And then thinking about novel treatments, including psychedelics, for example, to what extent is suggestion and suggestibility a sort of key ingredient of that? And therefore, would that change patient selection for those sorts of treatments? And then also thinking about whether we can, our knowledge about people's suggestibility would help us predict people who are more likely to get side effects from interventions. And maybe we could pre-inoculate them as well, as we were hearing earlier. So I hope that was interesting, and Devin and I would be very happy to answer any questions. Thank you.
So shall we start with the audience? A question from the audience? Rich, let's go.
Beneficial effects, and then the priors then get updated again with the kind of functional cause.
It's interesting, isn't it? And I don't have a fantastic answer to that question, but it's interesting the effects can be short-lived. I mean, that's not with everyone. I'm sure all of us have seen people who've had, you know, a placebo of some sort, even an active drug like that, which doesn't have not going to expect it to have a big effect, and people have just got better. But I think that it's about thinking, you know, the predictive processing ideas behind functional neurological disorder are just a small part of the whole thing. And all of the contextual and other factors around it may well be much more important. And that was kind of my point really with placebo. You don't turn any of those off. You just sort of magically get rid of people's symptoms. And so if those problems are there, it's them that's potentially driving the system to work in this way, malfunction in that way.
We've got a question online. So this is from Biba Stanton saying, I was really struck by the recent study showing that imaginary pills were effective in reducing test anxiety. I wonder if we can draw on aspects of that approach to think about how we can incorporate more self-efficacy into placebos as treatment.
Yeah. I mean, so there was a recent study showing you could use imaginary pills, and you spend some time and you take the imaginary pill, whatever that means exactly to take an imaginary pill, but you do that regularly. You're committed to it. And there seems to be some efficacy for that. As with anything else, I'd like to see how well that replicates and how generalizable that is. Some of the open label placebo effects, there have been some inconsistencies there, and sometimes the open label placebo effects don't come through when you look at open label nocebo, for example. So that would be one concern there. Just to Mark's point, though, is that you know, I'm less familiar with this because I'm not a clinician, but you can use self-hypnosis and you can give suggestions to yourself. And so that might be one way of kind of training participants to kind of take over and have greater self-efficacy by giving themselves suggestions. Yeah.
Okay. Oh.
Hiya. Thank you for a very, very fascinating talk. There seems to be some tension, I think, between how you sort of set up those prior expectations and how open, you know, patient can become to suggest suggestions. I think we're all quite aware of that sort of tension of how there's lots of mythology or sort of myths, I guess, around FND being quite untreatable. And I think there's a lot of sort of friction between how the clinician kind of validates or doesn't validate that expectation within the patient. It seems as if the less the clinician validates that myth, for example, that it is untreatable, the more skeptical the patient becomes towards the physician, and therefore the less likely they are to kind of be open to placebo in a way. And I share your concern about sort of treating with magic and essentially kind of medicalizing and solidifying this kind of cultural concept of this, you know, untreatable thing. So my question is there any data about sort of disclosing after the fact to patients that actually what has just cured their treatment is placebo? Does that lead to remission down the line, or does that actually function sort of like a inoculation to sort of future misinformation in a way?
So I only have, I don't know whether you, Devin, have more experience. I mean, I only have anecdotal evidence that for example, that person I showed you with botulinum toxin, I told her afterwards that this effect was not an effect of the botulinum toxin. Instead, this was demonstrating that it was a change in belief and change in expectation. It shows that something different was possible. But my experience of doing that is that people find that extremely difficult to understand, and that they will be in a situation where they say, well, yeah, okay, whatever, but can I have the botulinum toxin again? And so I've always found it difficult to manage that explanation afterwards. I think your other point about the sort of chronic nature of functional symptoms is a complicated thing, because I've had many patients who said to me, the doctor came and saw me on the ward round and said, oh, it's great news, you have a functional disorder, you'll be up and walking in a couple of weeks. And then I wasn't, and therefore the diagnosis must be wrong, and they're all rubbish. It's complicated because you want to generate optimism, but at the same time, you don't want to set yourself up in a situation where you're then denying what we actually know to be true, which is most people remain with symptoms. And so I've certainly changed my language a lot and start to talk about, I don't talk about getting better. In fact, I rarely say I say, improvement, maybe symptoms reduce a bit, better able to manage with symptoms, because that feels more realistic. So I think that excess optimism has a danger as well, because it's likely to be refuted by what we know to be the clinical reality.
Yes, sorry.
Hi, thank you, Mark. Excellent talk. If you look at all the research in medicine, and if you look at specifically in psychiatry, probably placebo as a group is probably one of the most effective treatment that we don't use. It's interesting to see healthy people were quite open. Patients probably were not as open. Health professionals really skeptical about it. But if you look at the patients, they try and receive placebo response through either complementary therapies, food supplements. So they really want it. They want that placebo response or whatever enhances it. How do we break that? Because I think that's one of the most effective treatment that we are not harnessing in modern medicine. How do we break that skepticism? I think that's one of the big issue.
I'm just speaking from a kind of personal point of view. I think that if we do what Devin was saying about understanding much more about the mechanisms, and if we can draw in the sort of all of the wealth of evidence there is, or information there is, like from the hypnosis literature and so on, we can actually just integrate it more into clinical practice without it having to be a separate thing. Now I'm going to give you a placebo. So I think my take from that survey is that people are open to the idea that actually there's another thing going on, there's another system there which we can tap into, and maybe we should be using that. But I think that the sort of way that placebos are delivered is probably not the best way we could do it, and that maybe we could integrate all of that learning and into our clinical practice in a slightly different way. So I think you're right. It's there. It's a massive effect, but maybe we need to have a better way of delivering it.
So unfortunately, we're out of time, I'm afraid. We could talk for a long time on this, so thank you so much. And if we come back from refreshments at 11:05, please. Thanks.